So good afternoon, doctors. I'm Dr. Prachi from Shield Healthcare, and a warm welcome on behalf of Shield. We are ready with yet another exciting webinar, and today's topic is ovarian stimulation protocol. We have eminent speaker today, Dr. Surya Prakashmurthy, and ma'am is very kind enough to accept our invitation and to do the presentation today. Today's topic is ovulation stimulation protocol. I will share my screen. Ma'am is obstetrician and gynecologist from Tamil Nadu Hospital and Tamil Nadu Test Tube Baby Center from Mannargudi. Ma'am has advanced diploma in minimal invasive surgeries, also certificate course in laparoscopic gynecology. Ma'am has presented many papers in AICOG and more than 5 years of experience in managing high-risk obstetric cases and gynecology cases. Ma'am's areas of interest are advanced laparoscopic surgeries and also infertility and reproductive medicine. So with this, may I request Ma'am to do her presentation, and thank you very much. Over to you, Ma'am.
Ma'am, you can share your screen.
Yes, ma'am, we can see your slides.
Ma'am, you are on mute.
Ma'am, please check whether you're on mute.
Yes.
Yes.
Am I audible now?
Yes, ma'am.
Yes.
Okay. Hi, everyone. A very good evening. Greetings from Tamil Nadu Hospital and Tamil Nadu Test Tube Baby Center. I am Dr. Surya Prakashmurthy. This is the first time for me for doing a webinar for Shield. Previously, I have done for Hindustan Unilever and Abbott companies for Bharat Serum. And this is the first time I'm doing it for them. And thank you so much for giving me this wonderful opportunity to share my knowledge and my experience in treating IVF patients. So far, because we have our test tube baby center for the past 15 years and delivered successfully more than 1,000 ICSI babies. So it's my pleasure to join my personal experience in treating those kind of patients in different scenarios, right? Without wasting any time, we'll just move on to the topics proper. Coming to the protocols. Yes, ovulation induction. What is ovulation induction basically? Basically, ovulation induction is inducing the follicular growth or inducing to achieve ovulation in a patient who are non-ovulating. I mean, chronic anovulation will be there. In such scenarios, it is our aim to induce ovulation in case of PCOS in order to achieve either monofollicular genesis or multifollicular genesis in case of IVF. In a regular patient who are a PCOD or might be non-ovulating, maybe due to various reasons, we just want the ovulation to happen. In such scenarios, it is our aim to improve the ovulation by giving certain medications and gonadotropins, right? The patient may go for single follicle development or multifollicular development. In certain scenarios, we need multiple follicles. As in the case of IVF, oocyte retrieval, we want a number of follicles to be adequate enough so that at least we can get 3 to 5 good amount of embryos so that it can be either it's a fresh embryo cycle, we can transfer it immediately, or else we want to freeze the embryos, we can freeze it. So we can take over of the entire cycle proper, and we can decide whether it has to be used now, or if you want to vitrify it, you can use it for later, right? So what is controlled ovarian stimulation? Basically, controlled ovarian stimulation, it includes three basic elements. That is, we are giving medications, adequate medications are given to improve the ovulation for that patient. At the same time, apart from medication, certain parental preparations are there. Parental means injections, gonadotropin injections are there. Either human menopausal gonadotrophins or the urinary gonadotrophins or recombinant preparations are available. Various preparations are available in the market. So gonadotropin injections are there. In addition to the gonadotropin injections, we are giving gonadotropin, that is GnRH agonist and antagonist, right? At the same time, this agonist and antagonist can be used not only for inducing the ovulation, but also it can be used as a trigger. Trigger basically, it is given to induce the ovulation, then we can retrieve the oocytes. So these three basic elements include the controlled ovarian stimulation. Basically, controlled ovarian stimulation is otherwise called as cost-less protocol. This is widely used in the field of IVF, right? Okay. So coming to the ovulation induction, what are all the drugs we are using? Before knowing the ovulation induction drugs, we need to understand one simple classification, that is according to WHO classification. And we will call this class 1, class 2, class 3, and class 4 is recently being included. We all know WHO, according to WHO classification, type 1, it's hypogonadotrophic hypogonadism. That is some abnormalities in either in the hypothalamus or in the pituitary, right? If it is class 2 is normogonadotrophic normogonadism. 70 to 80% of the PCOS people fall into this category. If it is class 3, it's hypergonadotrophic hypogonadism. Hypergonadotrophic means mostly it happens in case of ovarian failure, that is premature ovarian failure, either in case of Turner's or any genetic abnormalities that could have affect the ovaries, ultimately lead to increase in estradiol. So that is class 3. And class 4 is recently included, and that is nothing but hyperprolactinemic anovulation. In such scenarios, the prolactin level will be raised. At the same time, FSH will be normal and estradiol is reduced. This is type 4. So whenever a patient drops in the clinic, we need to classify to which group she belongs. Then only you can customize the protocol and treat accordingly. It is not like mathematics for universal, for everybody you need to monitor those injections, or it's not like that. So we need to classify and categorize the patient and treat her accordingly, right? So coming to the ovulation induction, it is the oral agents. Of course, everybody knows it's clomiphene. Clomiphene citrate is nothing but SERMs, selective estrogen receptor modulator, and of course, tamoxifen is a SERM, selective estrogen receptor modulator. Then aromatase inhibitor. These are all oral preparations. Aromatase inhibitors is commonly letrozole. And other injectables are available. Injectables means gonadotrophins. Coming to gonadotrophins, there are various preparations are available, right? Usually what happens is previously only urinary preparations are available. Nowadays we have recombinant preparations, then highly purified urinary preparations. Then we have triggers itself, we have urinary, highly purified and recombinant versions. Okay, so various preparations are available in the market. Before selecting those, we need to determine which will be appropriate for which category of the patients. Then only, for example, we have to, whenever a patient is coming to our clinic, we have to classify them according to the ovarian response, whether the patient is a normo-responder or whether the patient is a poor responder or hyper responder. A response, in the sense what I'm telling is, depending upon the number of oocytes she's developing. Suppose in case if she's having any 5 to 8 oocytes, means it's a normo-responder, or else less than 4 follicles are developing, we can categorize, put her into poor responder. So we need to categorize the patient and we need to customize the protocol. That is the most important priority. That's what I'm practicing. Okay. So we'll move on to the clomiphene. What is that? We'll see as a short introduction about clomiphene citrate. Basically, clomiphene citrate is, as I said already, it's a selective estrogen receptor modulator. Of course, it's the first choice of drug in case of anovulatory PCOS. And what is the FDA approved recommendation dosage for clomiphene citrate? We can start the patient with a dosage of 50 mg per day, right? At the max, we can titrate or we can increase up to 150 mg per day. Okay, so totally, if you ask me for the entire treatment cycle, we can go at the max 750 mg per treatment cycle for clomiphene citrate. Sometimes what happens when you administer clomiphene, basically it's an estrogen receptor blocker or antagonist. So antagonist, what to say, it blocks the negative feedback of the endogenous estrogen inside the body, ultimately result in expression of the gonadotropin receptors in the hypothalamus. Ultimately that leads to, since the negative feedback mechanism is running inside the body, it definitely leads to increase in the production of gonadotropin, that is your FSH and LH. Ultimately that leads to folliculogenesis. So this is basically the mechanism of clomiphene. Then what is clomiphene citrate failure or clomiphene resistance? You are administering a clomiphene citrate to a particular group of patients at the maximum dosage of 150 mg per day for 3 to 4 cycles. If the patient is not responding or not ovulating, we are not getting any positive pregnancy rate, then that particular cycle is clomiphene citrate resistance or clomiphene failure cycle. Right? It's not working, then we can switch over to either aromatase inhibitor, or we can get add upon with the gonadotropins, whatever it may be, either it's urinary or your recombinant preparations, we can add the gonadotropins as a add back therapy, right? Then what else I need to tell about clomiphene? That's all. Then tamoxifen. Tamoxifen is another non-steroidal. It's a selective estrogen receptor modulator. I think what happened? Yes. Yeah, tamoxifen, it's a selective estrogen receptor modulator. It has an ovulation rate of 50 to 90% and pregnancy rate of 30 to 50%. What it in what way it improves the ovulation means, it has apart from its role on antagonistic role on endometrium and all, it has a direct effect on the ovary. Thereby, it improves the folliculogenesis. You can administer in a dosage of 20 to 40 mg per day. From day 2 to day 3 till day 5, we can administer this tamoxifen. It has a beneficial role. At the same time, in IVF, we are using tamoxifen. Previously, we used tamoxifen. Nowadays, we are not giving because it has a similar action to other. Sorry, no slide change. Yes, sure. Yeah, this is what I explained previously. This clomid 1 regarding the use of clomiphene. Okay. So in this slide, you can see clomid is given initially at a smaller dosage, very smaller dosage of 50 mg per day for 5 days. And then we are seeing whether ovulation is there or not. If ovulation is there, if we are getting any increase in follicular count, or else how to test the ovulation is happening or not. There are so many markers apart from the development of follicles in the scan. We can see the endal follicle count, or else we can measure the estradiol levels. We can do serial scanning at day 7, day 9, day 11. We can monitor whether the dominant follicle is growing or not, or we can measure the estradiol levels. If the estradiol levels are greater than 300 to 400 picogram on day 5 or day 7, then it's a good amount of follicle are developing. If the patient starts responding to clomiphene, you can titrate the dosage. There are so many protocols are there to titrate the dosage with clomid along with gonadotropins. You continue the treatment, or you can use clomid as well as 3 to 4 cycles. If the patient is not responding, then we can do regime. A regime that includes your letters of the drugs. Yes. Yeah, this I said already. That is your aromatase inhibitor. That is the letrozole. Basically, aromatase inhibitor, it's the inhibition of the enzyme, competitive inhibition of the enzyme aromatase, which converts the androgen to the estrogen in the body. So what happens, that is estradiol negative feedback mechanism occurs. So the FSH level starts rising, ultimately resulting in folliculogenesis. What is the half-life of LH? LH is basically has a half-life of 48 hours. So it has a minimal side effects do happen with the aromatase inhibitors. We have seen patients who respond beautifully with letrozole. We might not experience that kind of response in clomid. If you put the patient on letrozole, there are so many preparations out there. I will share a few scenarios, then I will tell the protocol how to use the letrozole wisely. If the patient is obese, I mean obese PCOS, BMI is greater than 30 to 35, definitely that's an indication to put the patient on letrozole. Or the patient is PCOD, polycystic ovarian disease with clomid resistance. Already we have treated her with clomid. If she is failure clomid resistance also, we can put them on letrozole. Or is the cases of unexplained infertility, or in case of poor responders, we want to administer letrozole with so that we can put the patients with along with metformin also, we can treat the patient for better ovulation, right? So, so there are so many people were there initially. Previously, what happens is we put the patient on letrozole from the dosage of 2.5 mg per day, day 2 to day 6. We'll monitor the follicle development on day 9. If the follicle development is there, or else estradiol starts rising, it is a good positive sign for us to continue with the letrozole. Or else when we are doing a transvaginal ultrasound, the follicular study on day 7 or day 9, if we won't get any proper follicle development, either we can step up the dosage or we can introduce human menopausal gonadotrophins. Basically, that is FSH and LH. Suppose if you are using various brands are available in the market, I mean, if you are administering a dosage of HMG 75, that includes both your FSH and LH 75, or else if it is HMG 225, I mean it's FSH 225 and LH 225. So we can step up to 450. So starting from a dosage of 75, we can go up to 450 dosage. We can definitely see a beautiful follicle development in such scenario who are poor responding or who have previously failed cycles with clomiphene or letrozole alone. In such scenarios, the addition of gonadotropin to the patients definitely has a good outcome. So metformin, coming to metformin, of course, it's a biguanide, insulin sensitizers. It has a beautiful role in case of ovulation. Yes, not only it acts as an adjuvant in patient, it also reduces the serum testosterone. It improves the insulin sensitivity. At the same time, it decreases the hepatic glucose production. It also improves the insulin stimulated peripheral glucose uptake by liver, skeletal muscle, and adipose tissue. So it will be ideal for those patients with PCOD and obesity, along with type 2 diabetes mellitus, right? If the patient is having a clomid resistance or a chronic PCOD who is chronically anovulating with type 2 DM, we can put them on metformin depending upon her age, depending upon her BMI. We can start the dosage. We can start from 500 mg per day till 1.5 grams we can give. We have seen patients who have a beautiful weight reduction starts responding nicely with metformin alone. Yes, we have put them on 850 mg BD to those patients who are obese with PCOS with type 2 DM. They started responding beautifully with along with ovulation do happen with certain modifications in their lifestyle, right? So according to Eshrey, we'll move on to next slide. So, this slide is regarding the prerequisite for ovulation induction. The prerequisite, I mean, before putting the patient on ovulation induction, we need to monitor the size of the follicle and we need to concentrate on the endometrial thickness, right? So for ovulation induction protocol, starting on the day 2 or day 3, these are all the things we need to take care of. So before starting the patient, what else we need is the good endometrium should be there. Sometimes when you treat the patient either with letrozole or clomid or gonadotrophins, the endometrial development will not be there. In such scenario, all the effort you put will ultimately have a negative outcome. So it is a priority to improve the endometrium as well. You can see at the stage, we need a good endometrial development after the follicle development. I mean, after the dominant follicle development. That is greater than, if the follicle goes beyond 18 mm, we need a good endometrium of at least 8 to 10 mm. That increases the chances of conception. You just check for endometrial development. Look for the trilaminar view. If the endometrial development is not there, definitely we can add estradiol supplement also during the initial first 14 days. From day 8 to day 12, we can add estradiol preparations. Various preparations are available. Tablet Proginova is there, tablet Estrabet is there. So many good preparations are available in the market. So we can put them on estradiol from day 8 to day 12, depending upon the dosage, because the dosage varies. We need to customize. The basic dosage is 2 mg per day. You can titrate to 8 mg per day from day 8 to day 12. It yields to a good endometrial development, right? Okay. So yeah, this slide is very important. Types of ovarian stimulation. Basically, it has a natural cycle, modified natural cycle, and mild stimulation, and our conventional ART. That is what is that? Controlled ovarian stimulation. Yes, If it is natural cycle means no medication is there. So as such, a single oocyte development is expected. If single oocyte is developed, then no issues. Definitely, there is an increased chance for conception. What is modified natural? Modified natural in the sense it's a HCG only treatment. HCG only means trigger alone is given, right? HCG is coming to trigger. Various preparations are there regarding HCG trigger. Urinary HCG is there, recombinant HCG is there, highly purified HCG is there. If you take urinary HCG, various dosage is also there from 5,000 to 10,000. I routinely give 10,000 units for patients who are chronic anovulation with PCOD. I'll put them on 10,000 HCG, because if you give 5,000, we won't expect that the follicle to get ruptured. So what I do is initially I'll give 5,000 units HCG, then I'll wait for 24 hours and then I'll do a scan again. If the follicle has not ruptured, then I will give another 5,000, right? So that is urinary HCG is there. Then recombinant preparation is there, and highly purified version is there. So modified natural means it's a HCG preparation. As an add back, we can add our gonadotrophins, right? Then coming to mild or minimal stimulation. Mild or minimal stimulation, the routine administration of gonadotrophins in a lower dosage. We can expect up to 2 to 8 oocytes in that cycle. Our conventional, as I said already, it's controlled ovarian stimulation. So that includes your GnRH agonist, antagonists along with your gonadotrophins, right? In such scenario, if you are using the controlled ovarian stimulation protocol, definitely we can expect a cohort of follicles. We can expect a multiple follicle development in case of our controlled ovarian stimulation. That's what we follow in IVF. In such scenario, by adding letrozole with that gonadotrophin injections, we can prevent the occurrence of OHSS as well, because adding letrozole in such scenario definitely inhibits the expression of VEGF. Thereby, we can reduce the risk of OHSS, right? In our setup, definitely, if the OHSS happens, we can manage. At the most scenario, we just try our best to prevent the OHSS to happen, because it has a huge impact on the economical, and not only on the economical, psychological aspect of the patient, right? The response depends upon the FSH LH receptor, their prior performance, everything is convey you. Yeah. What are all the markers of ovarian response? Basically, if the has hyper responder women, possibly of PCOD. Okay. Coming to the next slide. Yes, this is such an important slide. GnRH preparations. Basically, the GnRH preparations include what to say, agonist and antagonist, right? Agonist means there are so many preparations are there for GnRH agonist. Agonist, initially what happens is it stimulates, there is a flare-up effect is there. So because of the initial flare-up, there will be a stimulatory effect on the folliculogenesis. If you keep on administering them on a continuous aspect, what happens is there's a negative feedback. A desensitization and downregulation of the receptors do happen, then ultimately prevents the LH surge. It arrests the premature LH surge, thereby causing a negative impact, right? That's what happens in case of long protocol of GnRH administration. What happens in GnRH antagonism? There is a competitive inhibition of the GnRH receptors, then definitely it prevents the LH rise. So it prevents the premature LH rise, thereby it inhibits ovulation. So basically, we are taking control of the entire cycle. That's what happens in IVF. Either you administer GnRH agonist or either you administer GnRH antagonist. whatever it may be, 30 to 50% is the overall success rate. That we need to add. Okay. So coming to the antagonist protocols, yes. So in this, I need to say, just a sec. Yeah. If you take a GnRH agonist, basically it has lupride, buserelin, and goserelin is there. If it is a decapeptide, then triptolin preparation or naphrelin is there. GnRH antagonist, its cetrorelix and ganirelix are widely used. In various dosage, it is there. So before starting, as I said already, so before starting the treatment, we need to categorize the patient. If the patient is a hyporesponder, or if the patient is a poor responder, or it's a normoresponder, we need to customize the dosage according to the patient. So what is GnRH antagonist protocol? Antagonist, in the case of oocyte pickup, or if you're planning, what we do is prior treatment, 14 to 20 days of ossiples, we just start on day 2 of gonadotrophins, right? So in antagonist cycle, single dose is there, multiple dose is there, antagonist. Okay, if it is a single dose, what we do is just cetrorelix 3 mg is given as a single dose preparation on day 2 or day 3. If it is multiple dose, it is either fixed or flexible. Fixed in the sense, we administer cetrorelix, that is your GnRH antagonist, on day 5 or day 6 of your cycle. That is fixed. What is flexible? Flexible is administration of GnRH antagonist, that is 0.25 mg preparation is there, that is multiple dose vial. So you have start administering antagonist on the depending upon the growth of follicle, or depending upon seeing estradiol measurement. So whenever the follicle reaches its dominant size, I mean greater than 16 mm or 17 mm, you give your GnRH antagonist. That is flexible protocol. So basically, antagonist protocol is classified into single dose and multiple dose. Single dose means it is constant, administering depot preparation 3 mg, right? The effect usually lasts up to 4 days. If it is multiple dose, you categorize into fixed dose and flexible. Fixed dose means day 5 or day 6 of stimulatory cycle. If it is flexible, you decide whether it's day 5 or day 6 or day 7 according to the follicle development or according to the estradiol levels. That's what this antagonist protocol is. Yes. Okay. Coming to the agonist protocol. In agonist protocol, we need to understand a few basic things. Okay. Long protocol is there, short protocol is there, I mean flare protocol, then microdose protocol, ultra short protocol. 4 protocols are there. In which scenario we use long protocol? Long protocol means what is that? On the previous day of the cycle, previous menstrual cycle, on the 21st day itself, we start giving GnRH agonist. It's lupride. Okay, lupride is available in various preparations. Is available in a strength of 1 dosage. We get vials up to 4 milligram dosage. That has to be, the patient has to take and self-administer themselves on a daily basis. Okay. So if it is a long protocol, on the previous cycle date, from day 21, we'll administer the lupride till the day of trigger. That is called long protocol. It is not used nowadays quite often, but we are we have reserved this long protocol only with the patients with endometriosis, right? For patients with endometriosis, definitely we can downregulate them with long protocol. Then if you transfer, it will definitely yield a good clinical pregnancy rate, right? Then if it comes to a short protocol or flare protocol, what is that? Nothing. Administer lupride on day 2 or day 4 of the cycle, right? In a dosage of 1 mg daily from day 2 to day 4. Then we can serially titrate or reduce the dosage to 0.5 milligram daily till oocyte pickup. Then ultra short protocol. If it is ultra short, administer your gene agonist on 1 or 3 days. Microdose is nothing but reduce your dosage. So treat the patient with OCPs for 14 to 21 days, followed by lupride 40 microgram BD dosage from day 2 till trigger. This is what is called microdose protocol. So there is no point in getting confused. Just 4 protocols. Be clear with that. If it is protocol, till the day of trigger, if it is short or flat protocol, day 2 to day 4, you can start. Then reduce the 2.5 milligram daily of luprate. That is short protocol or flare protocol. If it is ultra short protocol, GnRH agonist only for 2 to 3 days, not till trigger. That is ultra short protocol. If it is microdose, reduce the dosage. Right? I think it's clear now. Then coming to antagonist, as we saw already. Yeah, this is into and microdose. As I said already, microdose you can use to poor responder. Yes, antagonist protocol we have discussed previously. Yeah. And next one, induction protocol. Yeah, these are all various protocols are there using only your clomiphene citrate or letrozole. Various protocols are there, but this what we saw from a UG days onwards. That is entirely that is what given in SHA, the standard step-up protocol or step-down protocol. Here I'll tell the basic clinical scenarios. Yes. I'll share a few interesting clinical scenarios. Then accordingly, I'll share the protocols which we use. Okay, so you can take an example of a infertile woman because of PCOD. The clinical characteristic will be oligo-ovulation or anovulation. Certain hormonal features will be altered. I think like hirsutism or any male pattern alopecia will be there, or her testosterone might be increased. In such scenario, what we can use? You just start the patient on letrozole. Letrozole starting from then do a scan or day 9. We can also see the scanning at day 11 and day 13. This is basically infertility because of PCOS. A few hormonal alterations are there, along with clinical pattern is also there. Clinical pattern in the sense some acne marks or acanthosis nigricans, some hormonal issues also there. So basic treatment is treat her with letrozole and a lower dosage, 2.5 milligram per day from day 2 till day 7. Then we are doing scanning on day 7, day 9, day 11, right? And we are giving a trigger of HCG in a lower dosage, possibly by 5,000, or if you want to increase, we can increase the dosage up to 10,000 on day 13 or day 14, right? We expect the ovulation to occur between 24 to 36 hours. This is in case of PCOD patient. Okay. So in case if the patient has previous non-ovulation or clomid resistance, in such scenario, what we can give is, along with letrozole, we can combine the clomid in a dosage of 50 milligram per day from day 2 till day 7. Along with letrozole, 2.5 milligram per day from day 2 till day 10 we can use. I have used this protocol in patients with a poor response or patients with clomid resistance or patient who had previous clomid failure cycles. You just try this one for elderly women or who are having a poor ovarian response or who have poor AMH or poor AFC. If you try this one, definitely it will yield a good cohort of follicles, because I have tried this in few patients and I have succeeded in that too. In last month, one patient achieved a clinical pregnancy with this protocol. So the starting dosage is letrozole 2.5 milligram per day from day 2 till day 7. No need to titrate the dosage. Along with clomid in a dosage of 50 milligram per day from day 2 till day 5. If you want, we can increase the dosage of letrozole till day 10. This is regarding poor response. Okay. Then I will share another clinical scenario. So in case, yeah. Sometimes the PCOS women might be obese. In such scenario, if we start the patient on letrozole 2.5 mg per day from day 2 to day 7, we are seeing on day 8 a routine scan. If we are not seeing a good follicle development, then we can introduce gonadotropins. Gonadotropins, HMG, human menopausal gonadotropins. The starting dose, we need to increase the dosage, not from a routine 75 international units. We can increase up to 150 and 225 as the initial dose. If I say 150 HMG, it includes both 150 FSH and 150 LH. So you can also use HMG from a dosage of 150 to 225 as the starting dose in case of obese patient or those patients who have previously failed cycles. So give 75 or 150 dosage on day 8. You can titrate to 15 to 25% on the next day itself. So you can leave a gap of 24 to 48 hours. Then again a scanning on day 11 or day 12. Look for good follicle development. If you are able to see a good follicle development because of your gonadotropin, then it's okay. Continue with the same dosage. If you are not getting adequate response, definitely we can titrate the dosage. You can go at the maximum dosage of 450 international units till trigger. That definitely yields a good possible clinical outcome. Okay, then I'll share another scenario. Yes. Another scenario is administration of GnRH antagonist in patient with poor ovarian response. If we are seeing a poor ovarian response or previously failed patients, means we can start them on letrozole 2.5 mg per day from day 2 till day 7, along with GnRH antagonist, that is in the dosage of cetrorelix in the dosage of 0.25 mg per day when the follicle reaches greater than 14 mm. We can very well start the dosage of GnRH antagonist on day 5 till day 12. We can give the dosage in case of poor ovarian reserve, or if you want to give a minimum dose stimulation, we can use this protocol. Definitely it increases the clinical outcome of the patient. This has been in trial for several years. So the characteristics of the women with poor ovarian reserve, that include of advanced maternal age or high cycle cancellation, high miscarriage rate, or her E2 level might be very low, that is less than 3000, or she might have abnormal AMH level or poor AFC count. In such scenarios, along with letrozole, you can include GnRH antagonist in a dosage of 0.25 mg per day from day 5 till trigger we can give. This is in case of poor ovarian reserve patient. Okay, so the clinical tip in this scenario is adding the letrozole. Definitely that yields a good change and have a good clinical outcome. This I want to convey. And one more thing what I want to convey is the patient with endometriosis. So previously you could have seen a lot of patients with endometriosis. Yeah, this we have seen. Yes. What I have seen in my experience, there are so many patients with endometriosis will come for treatment, right? So we usually identify this endometriosis by transvaginal ultrasound or routine transabdominal ultrasound. We can look for any chocolate cyst or endometrioma. If the endometrioma is there, or if the chocolate cyst is greater than 4 to 5 centimeter, definitely that's an indication for lap cystectomy. While doing lap, we need to know about the severity of the endometriosis according to the grading. So if we remove the cystectomy, definitely there is a chance of recurrence for the patient to get endometriosis back. So we need to put them on Lupride either depot preparations or single preparations monthly once. What we do is Lupride 3.75 mg, that's a depot preparation, monthly once dosage. For up to 3 to 4 cycles we'll give, then immediately start the ovulation induction. What happens is, if you downregulate the patient with GnRH transfer immediately. We have got one portion of who downregulated, then finally embryo transfer has been done. Now she's pregnant 8 weeks of gestation age. Yes. So if you are getting a patient with endometriosis, you can either follow the antagonist protocol or previous down regulation, or else you can follow long protocol. I mean, till 21 days, you can continue the GnRH. Yes. Then, as an adjuvant Regarding adjuvant in ovulation induction, there are so many adjuvants are there. Adjuvant, I mean, metformin is an excellent adjuvant. Not only it sensitizes the insulin, it also reduces the hormonal level. It also aids in ovulation by decreasing the weight of the patient. We have seen so many patients with metformin, those who have reduced weight up to 8 to 10 kgs in 2 or 3 months. Then they can definitely, by achieving weight reduction, there is a role of improving in ovulation. So we have seen patients, those who got beautiful weight reduction, then achieved ovulation on their spontaneous without any add-on therapy. Ultimately, they will get conceived in 2 or 3 months. So when we talk about adjuvant, metformin is a beautiful adjuvant. At the same time, N-Acetyl cysteine, which is an excellent mucolytic drug, and at the same time, it's an insulin sensitizer. It not only improves the insulin sensitivity, also alters the thyroid level and lipid profile of the patient in PCOS. If you look into any PCOD women, definitely there is a chance of hypothyroidism or alteration in the lipid levels will be there. So if you put them on any sort of supplements, definite role is there. If not definite role, definitely it helps to certain extent in achieving the ovulation of the patient. So metformin is an excellent adjuvant. Then N-Acetyl cysteine. Then growth hormone also acts as an adjuvant. Then in case of poor ovarian reserve, this metformin and letrozole itself is a beautiful thing to get an ovulation, right? And there is a role of this pyridostigmine, which is an anticholinesterase inhibitor, thereby inhibiting the somatostatin level. It also improves the insulin sensitivity. Then it helps to certain extent in achieving the ovulation. So there are so many adjuvants like zinc, adding calcium or vitamin D to their protocols, treating the women with vitamin D for 3 to 4 months prior to embryo transfer. Definitely it has a beautiful role in achieving a good pregnancy outcome. We have seen patients who have got good results after treating with vitamin D. So there are so many supplements on there. Basically, there's a list goes on when we talk about the supplements, right? Okay. So yeah, this is the clinical study which supports the use of N-Acetyl cysteine to clomiphene citrate for ovulation induction in case of anovulatory infertility, right? I think I covered. Yes, thank you. Thank you so much for patient listening.
Thank you, ma'am. Thank you very much for this amazing presentation. Ma'am, you have covered all the agents, right from oral agents to injectables and all the protocols. It's really like a nice lecture series for us. And even I feel that I can do few protocols myself. I mean, that beautifully you had taken. So thank you very much for this amazing presentation.
Yeah. Thank you.
Yes, ma'am. And especially you have actually informed in which scenarios which protocols would be used.
Yeah. I just gone through those slides. Then I thought these are all the slides what we studied in our UG days itself. This chronic, step up, step down, low dose, everything we studied in our textbook of Shaw itself. Then your manager asked me, madam, whether you want any corrections or not. Then I told, no, I'll explain, I'll manage, because I have so many scenarios what we are daily seeing on a day-to-day practice. Then I thought I'll share some interesting tips and scenarios. Then it will be useful for those.
Yes, ma'am. Yes, ma'am. I mean, clinically, what is currently practiced, I mean, that is more important for the doctors rather than the theory. Very correct, ma'am.
Yeah.
Yes, so there is one question which, like, nowadays we prefer more of letrozole than the clomiphene. So, ma'am, do you really see any difference between clomiphene and letrozole?
Of course. In case of in case of obese women or in case of anovulation, letrozole is far better than clomid. There are scenarios where clomid is better than letrozole, right? So if a young woman is approaching you, I mean young women in the sense in the age group, if it is 20 to 25, if she is approaching you, not of obese category, newly married, you can start her on clomid itself. No need to go for letrozole, right? So if you start on low dose of clomid, you can get a beautiful follicular response. Okay, so there are certain criteria where you feel letrozole works better than clomid.
Right, ma'am. Thank you. I will be still waiting for more questions from the doctors who have joined this particular session. Ma'am, apart from that, I mean, this was my question also because we have a clomiphene with us. So we really wanted to understand what is the difference between the clomiphene and the letrozole, which you have rightly pointed out. There is one more question from Dr. Pavitra Sarat Kumar. I'll just read out to that.
Yes,
Yeah, I'm
yes,
taking
sure.
treatment last 2 years and I underwent for lapro and ovarian drilling. So now I'm
Okay.
taking some tablets. So for the pregnancy, so what is the next option? That is the question actually. So this is a patient, I guess.
Taking treatment for 2 years, only
Yes.
medications.
No, laparoscopy and
Sorry, I
ovarian drilling.
can't get only treatment for 2 years, right?
Yeah, the patient has taken treatment for last 2 years, underwent ovarian drilling as well. So I guess this is a PCOS patient. Some tablets she is taking, so I don't know what. So what is to be done next? That is the question.
Okay, I think she's my Instagram follower because I put the story on the Instagram. Might be my follower. Thank you for attending. Actually, Pavitra, hi for you. What you need to do is you need proper investigation. Whenever I see any infertility patient approaching me, they have all workup, right? The most important thing will be missed out. Okay, that is most important thing. What I say is your HSG. Do one HSG. Check the patency of the tube. Okay, so probably you have undergone laparoscopy, right? They would have done hysteroscopy or they would have done dye test for you. So check for the patency of the tube. Check for thyroid level. Check for prolactin, whether it's normal or not. Then you can ask your husband to go for a semen analysis. If look for his sperms, whether they are normosospermic, or you can also do a DNA fragmentation index. Because I have seen lot of women approaching to me. They could have done all the tests, possibly everything will be normal, but they could not have done any semen test for their husband. I don't know why the scenario is like that. So you can take a semen analysis for your husband. If possible, do a DNA fragmentation index. Look for the DNA fragmentation index, whether the criteria is whether the result is below 30 or above 30. If his DNA fragmentation index goes above 30, then his fertility potential might not be good. So you can ask him to go for a consultation or antioxidants, certain sperm improving drugs for 3 to 4 months. Then you can either try. You have done lap ovarian drilling, right? So you can go for ovulation induction up to 4 to 6 cycles. There is no point in achieving a single pregnancy in single cycle itself. Definitely there is worth trying of 3 to 4 cycles. You can give a try. If it is not working for you, then go for intrauterine insemination, that is IUI. Very well, you can try up to 4 to 6 cycles. I have seen patients who have conceived by 3rd to 4th cycle of IUI with previously multiple failures. So there is no point in losing a hope. Okay, Pavitra?
Correct, ma'am. Thank you very much. Thank you for that amazing session. Just a request from RN ma'am. Actually, there was the slides and the talk. There was slightly lag in between. So, ma'am, if you could just share the slide deck with us, we will try to post it that deck as well. So that's
sure.
So that's the request. So thank you, ma'am. Thank you very much. And we would like to see more webinars on our platform along with Shield Healthcare, ma'am. So thank you. Looking forward to your support. Thank you, ma'am. Thank
you so much. Thank you. Thank you for giving me this opportunity. Thank you.
It's our pleasure, ma'am. Our honor to have you on this platform. Thank you. Bye-bye.